February 7th through the 14th is Congenital Heart Defect Awareness Week, and congenital heart defects, or CHDs, are also known as holes in the heart. They're actually the most common types of birth defects. So Dr. Emmanuel Turner is the Chief Pediatric Heart Surgery at Rocky Mountain Hospital for Children. And Dr. Turner, how are these defects discovered?
Well, I'd like to say we've worked that out in our specialty. It's probably been around for about 60, 70 years. We don't have an exact cause and effect relationship. A lot of these kids are now being diagnosed prenatally with fetal ultrasound, but some are able to make it through the entire pregnancy, and we don't have any way of picking those up until the plumbing in the heart and the lungs kind of changes, and then you're able to start hearing murmurs. And then that's when we get a referral to a cardiologist and ultimately pick up the defect in the dividers for either the lower chambers of the heart or the upper chambers of the heart. We do know that there's can be some genetic component, meaning that it can run in families. And we're starting to get pretty vigorous in the research, looking at some of those components, because it's not just the defect itself, it also is some of the other lines that help with heart development that may also end up with the final congenital heart defect that ultimately presents and may need some kind of management down the line. Some defects, depending on where the hole is actually located, never actually need to see somebody like me. Nobody wants to see me, by the way, but if you do get to the point where the hole is necessary and needs to be closed surgically, then you would need to see someone like myself. Some of the holes are actually able to be closed with catheter-based interventions, so they can go up through the groin with a catheter and deploy a device and close the hole that way as well.
Interesting, absolutely. Do we know what causes these defects?
Another great question. Again, we're still working that out as our specialty is still, figuring out a lot of the kind of cause and effect relationships that other specialties have figured out. As I mentioned, there's the genetic piece. There are also some environmental factors that can be associated or have been associated in some studies that link to, what we call septal defects or holes in the heart. Specifically, smoking and drinking has been linked, but we really don't have a true timing of when that needs to happen, or we don't know the genetic predisposition that makes it a higher risk factor. And so before we get to the point where we're talking about public preventive strategies, we got to kind of work that out a little bit more, but we do know that there have been associations linked to some of those more environmental factors. I always get parents to say, what could I have done differently? And oftentimes I just reassure them and say, it's nothing that you did. This is just a very complex component of embryology, or how the body develops and how the heart develops. And there's a lot of different steps and a lot of different factors outside of actually just the heart development that ultimately influence where the heart sits, how the heart sits, and whether or not there's any holes in the things that divide the heart, both lower chamber and upper chamber.
Right, it's very interesting. Are there any long-term effects of having a CHD?
Well, I think that's a great question. So when we look at our highest population now, it's the adult congenital patients. And so these are patients that were initially born with congenital heart disease who've lived, to the point where now we've gotten so good that our patients are surviving into their 50s, 60s, and 70s. And so that's probably the biggest population of congenital heart disease patients now. It depends on the stratification as far as the complexity of the congenital heart defect when you're born. Obviously, the more complex the congenital heart defect, the earlier we're going to need to fix the defect. And so that's going to make that more of a longer term congenital heart problem or medical problem, if you will. When we start to really truly look at our population of adult congenital patients, we can almost look at this like a chronic disease. And so the more complex congenital heart disease that gets initial repair, has another repair probably, late teens, early 20s, and then it needs an additional procedure, whether that be cath-based or surgery, later in life, somewhere 40 or 50s. And so they actually require monitoring and surveillance throughout their lives. And so when you say you need something longer term from a follow-up standpoint, you do for most of the more complex congenital heart disease. Now, if it's more of the simple congenital heart disease, so say for instance, we just have one hole at the top chamber of the heart. When we fix that, more than likely, that should be a one-time surgery and nothing else should be affected down the line. Although there are changes that can happen to the where we fix the hole in the top chambers of the heart. Usually it's nothing that requires any additional procedures later in life. So it's kind of based on the stratification of complexity of congenital heart disease as to whether or not it's going to be something that's going to be long-term and more of a kind of chronic medical problem as opposed to something that we fix early on and shouldn't require any additional procedures later in life.
Absolutely. Is there anything we haven't talked about that you want people to know?
I think two pieces that, and we kind of touched on it. One, adult congenital heart disease, as it being our #1 population and its fastest growing population, I would say that, you know, some people who've had repairs early in life and now have been kind of lost to follow, those are the people that we want to make sure we get in to see our adult congenital heart trained experts that we have here at Rocky Mountain Hospital for Children, to make sure they do get that almost 50,000-mile checkup to make sure things are appropriate and that they don't need additional, whether it be medical management, procedural management, or even surgical management. So that'd be a big push, given that it's the start of Congenital Heart Week. I also think another thing is the amount of research in several fields that's really exciting now. Now that we've been able to get surgical, speaking specifically from a surgical standpoint, now that we've been able to get patients to really survive and do well after even the most complex heart surgery early in life, I think the next step is to make sure that we figure out how to make sure they're active and you know, successful members of society. And so we're looking at some of those collaboratives with other programs around the country to see what things are necessary, what resources are necessary to make sure that we get these patients after they have surgery early in life, and you know, back kind of with the general population. I think that's one big thing. And then the other issue is quality, and that's something that I've always thought is really important to any program. And as we see more of these collaboratives between other programs, help bring up the level of all programs from a quality standpoint, and ensure the best outcomes for all our congenital heart patients.
Absolutely. That's great information and great advice to make sure people are getting their checkups. Thanks so much, Dr. Turner, for joining us. We really appreciate it.
You're welcome. Thanks for having me.
Of course. And Congenital Heart Defect Awareness Week goes through February 14th. We'll be right back.